Okay, I think we're ready to start. Actually, we start 5 minutes a bit earlier so that we can get on time and have enough time for questions. I'm actually honored to start this session. I'm Amr Shalaqani, and I'm honored actually to be co-chairing with Major General Amgad Munir. He's a consultant at the Army at the International Hospital in Cairo. And this session actually will be about on IV techniques and protocols. And our first speaker actually would be Professor Yutaka Osuga. He's a professor of gynecology, Graduate School of Medicine, the University of Tokyo. He's a deputy director, the University of Tokyo Hospital, president of Japan Society of Gynecologic and Obstetrics Endoscopy and many invasive therapy. He's a president of Japan Society for Reproductive Medicine. A lot of titles. We're looking forward to his presentation on how to prepare the endometrium in ERT for endometriosis, adenomyosis, and fibroid. Please, sir.
Thank you, Chairperson, for a kind introduction. And the title of my talk is How to Prepare the Endometrium in ART for Endometriosis, Adenomyosis, and Fibroids, 3 diseases. And fibroids, adenomyosis, and endometriosis are very often encountered when you treat patients with infertility. And they have many in common, but also they have many different characteristics. So I'll talk one by one. And first, fibroids. And so there's many possible causes responsible for the detrimental effect of fibroids on fertility. And as shown here, highlighted ones are related to implantation. So many factors are related to implantation in terms of the bad impact of fibroids on implantation. And due to time constraint, I just talk about disturbed peristalsis. And a fibroid increases the peristalsis of the uterus, very often, and myomectomy decreases the peristalsis and improves fertility. And this is our study several years ago. And we found that fibroids are highly likely to stimulate the increase of peristalsis, so myometrial movement at the time of implantation. And as you can see here, so left-hand side shows the movement of the myometrium by CNMRI, and the movement here is 20 times faster than real. But anyway, after surgery, as you can see here, peristalsis decrease in its frequency. And actually, we found that the probability of pregnancy was much higher after surgery. So this is one reason why fibroids decrease the pregnancy rate, even though the fibroid is intramural. And we delved into the matter more precisely, and we did a lot of experiment. We found that movement, so the mechanical stress of the endometrium induced by peristalsis induced the expression of many cytokines or molecules related to implantation in the endometrium. And they seems to be worsen the implantation. And for example, the overexpression of IL-8 or neutrophil chemokines cause inflammation of the endometrium, and it would lead to implantation failure. So inflammation really there? So, yes, there. And we found that myomectomy reduced inflammation of the endometrium. And in this experiment, we measured a T2 relaxation time of the endometrium, which T2 relaxation time reflects the inflammatory status. And as you can see here, after myomectomy, T2 relaxation time decreased. That means the inflammation of the endometrium decreased after myomectomy. And then, what is clinical data? So we all know that submucous fibers or cavity distorting intramural fibers reduce fertility. So then, do non-cavity distorting intramural fibers impair the outcomes of IVFET? And this is an answer. And in this report by Erden et al. Found that, so in this meta-analysis, they found that intramural fibers at the size of 6 centimeter or less decreased the clinical pregnancy rate, as shown here. And likewise, fibers at the size of 4 centimeter or less also decreased the pregnancy rate, while fibers at 2 centimeter or less did not decrease the clinical pregnancy rate. So fibers over 2 centimeter could cause infertility even when there's no distortion of the intrauterine cavity. So then how to treat fibroid uterus for ART? So, generally speaking, so when the presence of fibroid is thought to be a cause of infertility, I think myomectomy is a gold standard. However, if it often takes time before infertility treatment when you do myomectomy fast. So, and the loss of time is unfavorable since the ovarian reserve decreases over time, especially after the age 35. And so to compensate the time loss, we developed the procedure named embryo cryopreservation before surgery, ECOBIS, as shown here. And in this procedure, we do oocyte pickup first, and the embryo taken is cryopreserved, and then we treat patient with GNH analogs and then do myomectomy. And after the healing of the myometrium, we do embryo transfer. And in our initial trial of this procedure, we found that no patients got pregnant when the number of frozen embryos was less or two or less, while around 60% of patients got pregnant when the frozen embryos number was 3 or more. Of course, it depends on the age, but we usually get 3 or more embryos frozen before proceeding to myomectomy. And now we use oral GNH antagonist because we have in Japan instead of GNH agonist injection. So in Japan we have GNH antagonist relugolix, so we usually use relugolix. And in addition, when the size of fibroid becomes less than 2 centimeters during the treatment, we skip the surgery since fibroid at such size won't affect the pregnancy rate. And the next one is adenomyosis. And here's a schematic overview of the abnormalities caused by adenomyosis that affect endometrial receptivity. And the figure is from our review paper. And a lot of factors are involved, but I don't go into details today. And practically, how should we do? And I think frozen thawed embryo transfer following GNH agonist pre-treatment seems to be the best choice at the moment. And the upper study showed that thawed embryo transfer following GNH agonist pre-treatment had higher clinical pregnancy rate compared to fresh ET cycles or fresh ET cycles with GnRH agonist pretreatment. And the lower panel shows that FET cycles following GnRH agonist pretreatment had higher pregnancy rate than frozen embryo transfer cycles. And however, there's contradictory data that GnRH analogs before FET is not effective. But I personally used GnRH antagonist before thawed embryo transfer when the size of adenomyosis is big, or it seems that the adenomyosis tick lesion seems to be the cause of infertility. And this is interesting paper by Lin et al. They found that oxytocin receptor antagonist during IVFET HRT cycles in women with adenomyosis increased the pregnancy rate when the adenomyosis is diffuse adenomyosis, not focal adenomyosis. So this oxytocin receptor antagonist, as you know, is atosiban. This paper seems interesting, but further study is needed. And occasionally, whatever treatment doesn't work for infertility caused by adenomyosis. In such a case, we may resort to surgical treatment, that is adenomyomectomy. We remove adenomyotic lesions as much as possible and reform the uterus as normal as possible in size and shape. And I showed the video yesterday. And this slide shows pregnancy outcomes after adenomyomectomy in our clinic. And among 40 patients, 33% got pregnant and 25% had live birth. Considering that the 40 patients were very, very refractory to any other treatment, any other medical treatment, 25% live birth, I think, is well acceptable. However, there are pros and cons in adenomyomectomy, especially in terms of pregnancy outcomes. As shown here, adenomyomectomy decreases preterm-prone preeclampsia and SGA, while it increases placenta accreta syndrome or caesarean section or uterine rupture. So we have to weigh pros and cons when we decide whether to do or not to do adenomyomectomy. And finally, I'd address very briefly on endometriosis. And as you know, endometriosis, a lot of factors are involved in endometriosis associated infertility, and many of them are related to dysfunction of the endometrium. And but today I do not touch on the mechanism. So just address how to treat it. And first, maybe this is everybody knows, and clinicians are, this is from ESHRE guideline, clinicians are not recommended to routinely perform surgery for variant endometrioma prior to ART because surgery is very, very highly likely to reduce ovarian reserve. So do not surgery before ART. So meanwhile, how about medical treatment? Medical treatment. So in terms of medical treatment, many adjuvant medical treatment before ART have once been shown to improve receptivity of the uterus, such as GnRH agonist pretreatment, GnRS pretreatment, and aromatase plus GnRH agonist and OC pretreatment. And theoretically, they suppress the activity of endometriosis lesions. However, the evidence of this adjuvant treatment is very, very weak. In terms of frozen thawed embryo transfer, it's been shown to increase. Frozen thawed embryo transfer has been shown to increase cumulative pregnancy rate here and cumulative live birth rate here. However, so this is a very important point. So the important data is clinical data, and recent studies suggest endometrioma do not affect ART outcomes. And all these papers endorse the notion. So we recently do not conduct medical pre-treatment in ART in women with endometriosis. And this is the final slide. This is our treatment. So this is our clinic, the standard of our clinic. So first of all, I have to say that our clinic holds a policy of freeze-all protocol in all patients. Maybe there is some objections, but anyway, our protocol is freeze-all. This is our premise. So on this premise, for submucous fibroid, we first obtain 3 or more frozen embryos, as I said, and followed by GnH antagonist, myomectomy, then embryo transfer. And for large intramural fibroid suspected to affect the fertility, we use the same treatment but skip myomectomy when the size of fibroid becomes 2 centimeters or less during GnH antagonist treatment. And for adenomyosis, we use GnH antagonist before ET. And in that situation, on that situation, we usually check serum 125 levels. And usually serum 125 levels decrease 1 to 3 month treatment of GnH antagonist. And after we confirm CH 125 levels are in the normal range, we do embryo transfer. And if any treatment wouldn't work, we do adenomyomectomy. So adenomyomectomy is a kind of last resort. And endometriosis, in which a lot of adjuvant therapy was advocated in the past, but now we do just freeze-all and embryo transfer without any medical treatment. And finally, so I welcome all of you to Japan, and I hold IFFS World Congress, April, the best season in Tokyo, and a lot of experts get together, and we are now preparing a lot of events, very interesting, and please come to Japan and check here. So this is QR code, and thank you very much.